Okay, now we're continuing with part 2 of our respiratory chapter here. We're going to talk about basic airway adjuncts. The first thing we're going to talk about is the oral pharyngeal airway, or OPA, sometimes abbreviated as. This device allows us to prevent obstruction by the tongue. So we put this in an unconscious patient. And when we place this correctly in an unconscious patient, it's going to keep that tongue off the back of the throat and allow air to pass freely. So this oral pharyngeal airway, if you take a look here, it comes in a variety of sizes from large adult all the way down to infant. And it can be used on any age child. They come in different colors and things like that. It doesn't necessarily, it just depends on who makes it, is what color it is or what exactly is going on with it. They're all basically the same. This specific brand has channels on the side where you can run a suction catheter along here to help suction out stuff. It's just as easy to use a rigid suction catheter and suction out the airway though. So we don't really use that often, but they come in a bunch of different sizes and you'll be able to find the size that's appropriate for your patient. It's sized by measuring from the corner of the mouth to the angle of the jaw. So basically from the corner of the mouth here down to the angle of the jaw, and you'll get the proper size. And you can kind of almost see if it was inside the oral pharynx that it would be helping hold the tongue off the back of the throat. So most important thing, you're shoving a big plastic thing in someone's mouth, they have to be unresponsive and without a gag reflex. If they have a gag reflex, they're going to vomit. You're going to gag them. There's a good chance that they're going to vomit. So that's a big contraindication. So we're going for a person who's unresponsive without a gag reflex. So you start to insert it. If the patient starts gagging, hurry up and get it out of there. Be prepared to suction because they may throw up. Apneic patients. If you have a patient who is not breathing at all, they've got to be ventilated with a bag valve mask. This only holds the airway open. It doesn't help them breathe. Okay, the other thing we have is a nasal pharyngeal airway. You can use this with someone with a gag reflex. This goes in the nose, obviously, and goes all the way back and does the same thing as this, as it helps keep the tongue off the back of the throat. So this is measured from the tip of the patient's earlobe to the tip of the patient's nose. So basically, you know, that distance across the patient. The diameter should be the largest that's going to fit, about the size of the patient's little finger. So you take the patient's little finger, you look at that, that should be a size that'll make it all the way in. If they've had nose surgery, if they've got other facial features that might interfere with that, maybe you have to go a little smaller, but you want to use as large as possible because they're going to be breathing. Basically, air is going to be passing through that tube. So you want a nice open channel. So about the size of the patient's little finger. You can use this with a person with a gag reflex. When you put this in, it has to be used with some sort of lubricating jelly. This is a non-petroleum jelly, so it's not Vaseline. Otherwise, it's going to cause damage as it goes in and cause the patient's nose to bleed. So we got a semi-conscious patient, unconscious patient. They have a gag reflex. We'll use the nasal pharyngeal airway. No gag reflex, we use the oral pharyngeal airway. So if you try putting that oral in and they don't tolerate it, go ahead and try to put the nasal in. Contraindications: severe head injury or fractured nasal bones, severe facial injury. You don't want to be shoving this in there because you have a chance, if the back of the nose is broken, either to displace those bones and cartilage or even possibly poke into the cranial cavity. All right. Another thing we can do to maintain our airway, use the recovery position. This is right out of CPR. We have a patient who's breathing. We've assessed them. They're breathing well. We're kind of waiting maybe for help to move the patient, or we're waiting for a treatment to kick in, or we're waiting for ALS intercept, whatever. You can roll the patient onto their side in the recovery position, just like what we do when we have ROSC with CPR. Patient, don't forget, they can't be a trauma patient, and they have to be breathing on their own. So, supplemental oxygen. We have the ability to give oxygen. If we have a patient that's hypoxic, we're going to give that patient oxygen. We're not going to withhold oxygen from a patient who might benefit from it, especially if we're assisting with ventilations. If we're assisting with ventilations, for sure, we're going to go ahead and give that patient oxygen with that supplemental assist with the ventilations. So the oxygen equipment, there's a cylinder. It's got compressed gas. Some ambulances, they don't use them in small portable tanks, but some ambulances actually have liquid oxygen. There's not any real difference on the patient's end. It's just how it's stored in the vehicle. Some safety considerations. You have a compressed gas cylinder. It's pressurized to 2,000 PSI. That is enough to drive a cylinder through a brick wall. We want to make sure we handle them carefully. If we drop a cylinder, it's got to come out of service. Something punctures that cylinder, most of the time they're pretty tough, but if something punctures that cylinder, the thing can turn into a missile. If they're you don't want to stand them up by themselves. So always have them in like the airway bag or some other situation. If they have to sit somewhere, they can sit on their side. It's just compressed gas, so it can operate in any position. Make sure the right regulator is on it. We'll show you when we do the practicals for this and how to set this up. There's a special way that the regulator has to go on. Don't try to modify any equipment to use oxygen. Remember, oxygen is an oxidizer, so it can enhance combustion. So we don't want to use this in anywhere where there's going to be a risk of fire. We don't want to use it in an area where there's greases and oils and things like that that can get on the threads, can actually start a fire. All right, so on the valve, which is at the top of the cylinder, there is a number of areas where pins can go in, and you'll see this better when we actually do the practical. Oxygen has a specific location where those pins go. Other gases have specific spots where their pins go. That prevents you from putting an oxygen regulator on anything but an oxygen cylinder. So, and again, we'll practice that thoroughly when we do the practicals for this. So the pressure regulator, it'll drop that pressure down to something that we can use therapeutically, about 40 to 70 PSI. We'll either use a quick connect or a flow meter, some sort of way so it just doesn't flood 40 PSI into the patient. There'll be an actual device that can knock the flow down, specific to the type of device we're using to deliver the oxygen. They're permanently attached to the pressure regulator on medical equipment. So you'll have a flow meter, or sometimes in the ambulances, you'll have it and it has a little ball that goes up and down with the oxygen traveling through it. All right. Oxygen itself doesn't burn or explode, but it can speed up the combustion process. So we have to keep fire sources away, make sure the area is adequately ventilated, and you don't want to leave that cylinder standing unattended. Like I said, we'll be on you if you do that, because if it falls over and knocks off the valve, it could become a missile. All right, oxygen toxicity. Not all patients need high concentrations of oxygen. If someone has COPD, for example, and they're using the amount of oxygen in their bloodstream to breathe, giving them too much oxygen potentially could reduce their respiratory drive. So we want to be careful with that, but we're not going to, again, withhold oxygen from a patient that needs it. When pulse oximetry is available, we're trying to go to about 94 or higher. You don't have to have 100. We want to at least get up to that 94 range. All right, so then those were airway adjuncts that help hold the airway open. We talked about oxygen itself. How do we get the oxygen into the patient? Well, there's a number of things. We can use a non-rebreather mask, and that's simply a face mask, and it's got a large bag on it that is a reservoir for oxygen. It fills up with oxygen. Again, we'll show you exactly how that works. Nasal cannula, that's that device that you see sometimes on TV, a patient sitting there and they have something resting right inside their nose. That's called a nasal cannula. And then we also have the bag valve mask. Sometimes they call that an AMBU bag. AMBU is a specific company, but sometimes generically they use that term. The bag valve mask is used for a patient who's not breathing or we have to assist breathing. The cannula and the non-rebreather mask, that's for a person that's breathing on their own. All right, so that non-rebreather, again, it's a bag with a mask. You can adjust the flow rate at your regulator so that the bag doesn't collapse when the patient inhales. So ideally, that's a reservoir for oxygen. Before we put it on the patient, we fill that bag up so it takes some shape. It's got oxygen in it. As the patient breathes, it shouldn't collapse it, but that gives them the opportunity to have up to 100% oxygen. Usually that's about 10 to 15 liters a minute, and that's how the regulator works. It's called liters per minute. They have trouble breathing, but they're breathing adequately. They're just hypoxic. So maybe their asthma is acting up and they can't just get as much air. So we're giving them a little boost there with that oxygen. Nasal cannula delivers 24 to 44% of oxygen. With that flow meter set, usually we breathe about 21% oxygen. 20 is more realistic, but approximately 20%. So this will up it to 24%, maybe at 1 liter, all the way up to maybe 44% at up to about 6 liters. Again, they have to be able to breathe through their nose. If you're going to have a really long transport, they make humidifiers. They have sterile water in them, and they'll bubble the oxygen through there. So it's humidified oxygen, so it doesn't dry out the nasal passage. Because you can imagine with air blowing across your nasal passages nonstop, it can dry them out pretty badly, and patient could be subject to nosebleeds and things like that and just uncomfortable. All right. Sometimes people have tracheostomies. That's a hole in the neck where they can breathe through there. You can use, sometimes they'll have special devices to deliver oxygen to that. Otherwise, you can place the non-rebreather or other similar device right over that opening. You can do that with a stoma. Stoma is just an opening without any hardware. Same thing. You can place the oxygen mask on top of that. All right. So when do we know when we have to actually start using that bag valve mask? When do we know that they have to have their ventilations assisted? Well, some could be an altered mental status. If you notice they have inadequate minute volume, we were talking about, perhaps that person is breathing 18 times a minute, except it's really, really shallow. Well, then we may have to assist those ventilations. If they're using excessive accessory muscles or they look extremely fatigued, you'll see that as they're trying to breathe and just struggling. Those are all indications that we may have to assist ventilations. So if they're breathing too fast, where they can't exchange that air properly. So if they're breathing rapid and shallow, that's another time where you would assist their ventilations. Air moves in the anatomic dead space and doesn't exchange pulmonary gas when they're doing that. So, you can have air trapped basically in the lungs. And because they're breathing so shallow and so quickly, it never gets that stale air out. So it actually has carbon dioxide and stuff like that in it. You're just not getting the exchange you should. So that bag valve mask, again, this is one of the most common things we use to ventilate a patient. It won't provide as much volume as doing like actual mouth to mask ventilations, like you do in CPR, generally speaking, with your pocket mask. But because you hook it up to a source and it's delivering 100% oxygen, you don't necessarily need the same volume. So let's say we're going to assist a patient with a bag valve mask. If they're conscious, explain it to the patient. You can time it so when they take a breath, you squeeze that bag just to put a little more volume into it. Takes a little practice, but it's doable. Got to go over the nose and mouth. And again, in CPR, we'll show you how this works, most certainly. Then every time the patient takes a breath, we would squeeze the bag. That's just assisting them. That's not breathing for them. It's just assisting them. So after the initial 5 to 10 breaths, you'll be delivering an appropriate tidal volume. Maintain that adequate minute volume. And watch for chest rise and fall when squeezing the bag. Chest rise, like you've probably learned in CPR, is the most accurate way of telling that a breath actually was delivered properly. So artificial ventilation, let's say they're not breathing. If they're in a respiratory arrest, they're going to need that immediate treatment in order to live. Once a patient's not breathing, we begin artificial ventilation. We could do mouth to mask, just like CPR. We can use a bag valve mask, which is probably most common for EMS. And then they also have automatically, or I should say manually triggered ventilation devices. We've gotten away from those because sometimes we can deliver too much oxygen and actually damage the lungs by overinflating them. So the bag valve mask is probably the most common. All right. So we have, when we're assisting, we have normal ventilation versus positive pressure ventilation. So we know when we take a normal breath, the diaphragm contracts, negative pressure is generated in the chest. And then through the open nose and open mouth, air will rush in to meet that. Positive pressure ventilation, that's when you're forcing air into the chest cavity. Some complications, we can actually give a little too much oxygen, air ventilation, and it can actually reduce the blood pumped by the heart because it increased intrathoracic pressure. You have to use more volume if you're doing a positive pressure. And you do run the risk, especially using just a mask, that you're going to force air into the stomach, causing gastric distension, causing a swelling. You can actually watch and you see the abdomen starting to swell. It gets to a point, there's a good chance that air is going to come back out again with whatever contents are in the stomach. So that's something we want to try to avoid. Mouth to mouth, which we don't use very much at all. We have to use a barrier device, but some barrier devices are just a shield over the mouth. And we can do then mouth to mouth basically with a barrier device. With the mask, you can do mouth to mask ventilations. And again, we'll go over this in plenty of with when we're doing CPR. Some of those masks have a port where you can plug in oxygen. And if you can do that and set the thing to 50 to 15 liters, you can deliver, instead of the 16 to 18% that your exhaled air has, you can deliver all the way up to 55% oxygen just by adding a thing to the port and doing mouth to mask with an oxygen assist. All right, bag valve mask, again, we're going to practice that enough times that you guys are going to be able to deliver an adequate volume. Be alert, though, for gastric distension. If their airway isn't all the way open and air starts entering the stomach, we can cause some problems. If you're having difficulty adequately ventilating the patient, switch to another method. We have the pocket masks. They're on every ambulance. You can switch to a pocket mask or mouth to a face shield, basically mouth to mouth breathing, and ventilate the patient that way. So if you're having a hard time, it's leaking, maybe they have facial features that are making it difficult to ventilate that patient, we can switch to something else that will ventilate them. All right. We talked a little bit about gastric distension. What is that? Well, that's when artificial ventilation fills the stomach with air. We want to make sure we're ventilating at the appropriate rate. We want to make sure the patient exhales fully before we deliver more oxygen. Want to make sure we're using the appropriate volume of air. We use too much air, then it's going to end up in the stomach. And that's something we want to avoid at pretty much all costs. Manually triggered ventilation devices, again, they're not used much. We really don't want to use them in pediatric patients. We really don't want to use them with people with COPD, chest injuries, things along those lines. So you may see them, they call them sometimes demand valves, where you can actually breathe from that, or you push the button and it'll force air out. Again, not used all that often, so hopefully we'll get a chance to show it to you, though. Okay, automatic transport ventilator. Usually, this is going to be used by more advanced services, but they do make ventilators. Some of them actually operate on oxygen. They have a small box that you can control the ventilation. Some of it's manual, some of it's all electronic, and it allows the patient to be ventilated and it allows you to free up. You have to use an advanced airway device, though. You can't just place a mask on somebody's face. It's, we're going to use it with an advanced airway. Either paramedics have intubated the patient or something called the King airway, something along those lines. And we'll show that airway actually to you later, too. Continuous positive airway pressure, or CPAP. So this is non-invasive. It's a great ventilatory support for people with respiratory distress. If they're having a hard time because of congestive heart failure or sometimes COPD, we can use that and create a continuous positive airway pressure to force air into the lungs, force the alveoli open, and sometimes it helps out quite a bit. Even can help them from getting intubated at the hospital by using the CPAP. So it increases the pressure in the lungs, again, opens the collapsed alveoli. It pushes actually oxygen across that alveolar membrane, forces interstitial fluid back into pulmonary circulation. So again, we use that with people with like congestive heart failure. It can actually push that fluid back out of the lungs. Patient, though, has to be alert, able to follow commands. They have to be breathing. The pulse oximetry, we're going to wait until it's about, well, we're not going to wait. We're going to try other interventions first. But really, the pulse oximetry needs to be like less than 90. We're not going to do this on someone with 96 SpO2. And they have to be showing moderate to severe respiratory distress. All right, if the patient's not breathing, we can't use a CPAP. If they have symptoms of a pneumothorax or they have chest trauma, we're not going to use that. Tracheostomy, because you put the mask on, it's just going to come out the trach. If they've got active gastrointestinal bleeding or vomiting, because we strap this to their head, they have to have the ability to still throw up and stuff if they have that vomiting or whatnot. So we don't want this in the way. And if they can't follow verbal commands, we can't use this. So you have to be able to talk them through it. It takes a little bit to get used to being on that device. So we're looking for between 7 and 10 of pressure there. And that's going to be, it's a setting actually on the dial, on the actual mask, usually on the mask. And that way we can get everything taken care of there. And yeah, it pushes open those smaller airways and keeps the patient a lot of times from getting intubated. Some people find it really claustrophobic. If they are very much hypoxic and they're not thinking quite straight, probably shouldn't put it on them in the first place, but they may not tolerate this. If they have, again, the possibility of a pneumothorax, we don't want to, or chest trauma, we don't want to put that on, because if it causes that pressure will force that pneumothorax, maybe even to be tensioned, and that's something we don't want. It can lower a patient's blood pressure because of that positive pressure and that change in thoracic pressure. It can change the patient's blood pressure. So if the patient shows signs of deterioration, we're going to take that off and begin ventilating with a bag valve mask. All right, talk very briefly about stomas and tracheostomy tubes. It's an opening in the neck, goes straight to the trachea. We're going to use the bag valve mask. If they need breathing assistance, we can place that bag valve mask right on there and breathe for the patient through their stoma. If they have some of them actually have devices where you can actually hook the bag valve mask to it. Otherwise, you just go ahead and place the mask on their neck, seal it up. You may have to seal the patient's mouth and nose with one hand to prevent air from leaking through the upper airways when you ventilate through a stoma. So you may try to breathe through that stoma and air may come out the mouth and nose and not ventilate the patient. So if that's the case, we have to make sure we prevent that leak. If sometimes we have patients with airway obstructions. So if that foreign body completely blocks the airway, that's obviously a true emergency. They're not being able to be ventilated because of the airway obstruction. Adults, a lot of times it happens during a meal. Children can happen anytime. They can be eating, playing with small toys, crawling. Infants up through some young toddlers, they explore their world through their mouth. A lot of times children will place things in their mouth and can easily choke on a toy. This will result in death if not treated immediately. They're not getting oxygen. It's going to make them hypoxic, can make them have cardiac irritability. And if nothing else, after a few minutes, they can start having brain cells die. Stuff that doesn't involve foreign bodies, one could be the tongue. Again, in an unconscious patient, the tongue is the most common airway obstruction. Could be swelling. So you get an allergic reaction or an infection like epiglottitis, something like that, can actually block that airway. But it's not something that, it's not a foreign body we can get out. And then trauma, finally, tissue damage from an injury. Suffer severe trauma, you can have swelling plus bleeding and other tissue problems, and that can also cause an airway obstruction. If the patient's got a mild airway obstruction, they can still exchange air, but they're having some respiratory distress. Maybe they're having noisy breathing, they're wheezing, maybe they're trying to cough, or it's a lower airway obstruction. It's got in there pretty deep. If they've got good air exchange, don't interfere with the patient's efforts. Encourage them to cough on their own. If they have poor air exchange, we're going to have to put them on supplemental oxygen, try to treat that as much as possible, including up through doing abdominal thrusts. Severe airway obstruction, patient can't talk or cough. The standard, just like CPR, universal sign, they grasp for their neck. They can't breathe, they can't answer questions. That's when we have to do abdominal thrusts, begin CPR with chest obstruction, with chest compressions if the patient goes unresponsive. All right. If they've got an airway obstruction, perform a head tilt chin lift maneuver to clear the tongue obstruction. If you can see the object, you can use a finger sweep with a gloved hand and maybe get that object out of the way. Abdominal thrusts are most effective, but that's in the conscious person. If they're unconscious, we're going to be doing chest compressions, chest thrusts, but it's basically the exact same thing as CPR. Dental appliances, crowns, bridge, dentures, parts of braces, they can get lodged and cause partial airway obstructions. Want to manually remove that before providing ventilation. If the dentures are well-fitting, leave them in place. Loose dentures, that should be removed. Facial bleeding. Airway problems can be challenging with severe facial bleeding. When someone's face has a very, very rich blood supply, any injuries can result in tissue swelling, bleeding into the airway. Try to control the bleeding with direct pressure, suction out as necessary. All right, so that wraps up chapter 10. In class, we'll go over the review, deal with some of these other topics. Go ahead and watch both videos so you get the entirety of chapter 10. Make sure you jump on the homework and take care of those other things, and we will talk to you later.